up. Another revises a CHP MNE framework to accommodate the new indicators in curative service in line with the new scope of work. And last one, develop and disseminate CHW quarterly newsletters for knowledge management and advocacy. And this activity take 6 months up to 1 year, and the support is that were needed is technical support, financial support, even political will. Thank you.
Yeah, thank you very much. Our clapping is too weak. Hippic. In Ghana, we say it's hippic. It's highly indebted. So let's give you another round of applause. You know, they did about 5 or 6 in one week, unlike other groups who just did one thematic area. So that's very impressive. So well done. Any comments? Any comments from anybody? Yeah, there's a hand here. Fatima, go ahead and stand there. Don't run away. Now, don't worry. Dr. Fatima is here to support you, so you don't have a problem.
Thank you very much for such a wonderful presentation. So this is Monica Bernard from Health Entrepreneurs, and it's lovely to see the progress that we are making both here in the Tanzanian mainland and in Zanzibar. So by listening the presentation from the Zanzibar group, and specifically on the finance, I'm trying to relate with the last group, the previous group, the Tanzanian mainland presentation on finance, and it looks like we are all speaking the same language, sustainable financing mechanism. And I believe if we are really into sustaining this progress, then we have to think of revolving funds. We have to think about innovation and technology, and that's all that it all matters in this strategy. So my thinking, and I believe that if we want to sustain community health intervention in Tanzania, then we have to consider a component where we can bring in multiple players from, for example, the private sector and the government sector to test different models whereby community health workers can be in a position to earn an extra income from the activities that they are conducting at the community level. And by so doing, this one is going to save a lot of money from the government. For example, I will just give an example of our health entrepreneurship model. So we provide a range of services at the community level, whereby community health entrepreneurs or community health workers are being capacitated on how they can supply personal hygiene products and medicines at a subsidized price. And by so doing, they earn an extra income out of the business um, while continuing to provide these healthcare services. And that has proven a really high retention rate of community health workers. So we have a program in Gaeta, and government officials once visited the program and saw what is really happening on the ground. And that was a point where we went to Uganda to learn about the model. And it turned out that the Gaeta model can be adapted in Tanzania. So for us to make this project sustainable, I think we have to, I believe actually, we have to think of the revolving fund, trying to see how we can sustain this project even after the 5 years that has been, that has been, that has been proven to work for this project. So that will be my recommendation. Let us think about entrepreneurship for the community health workers so that they can earn an extra income out of the services that they are providing. And yeah, looking on the ways to sustain the program. Thank you.
All right, thank you very much. Any other comments? Do you have any response? Generally, from her comments, do you have any reflection on that?
Um, Thank you, Miss Monica. Although I have not seen you, but I'm sure we shall catch up during tea break. It's it's a super comment, but I'm a bit skeptical unless maybe I go and see the Geita model working. I might understand better. As we said, these community health workers have that expanded package, both preventive and curative. And I'm a bit hesitant. When you give somebody an option that, they might get something out of this, they might concentrate more on the entrepreneurship side and uh, forget about chasing mothers who have not gone for their first 12 weeks of clinic. So I'm a bit hesitant, but well, I'll take the innovation, and I think we would be thinking about it. It's a great concept. I'm not sure exactly how it works, but we are taking it up. Thank you.
Thank you very much. Are we? Yeah, another one. Meanwhile, leadership and coordination, are you here now?
Thanks so much. So, in addition, is on the entrepreneurship. Yeah, Monica talked about their own entrepreneurship model, the health entrepreneurs. But I just want to comment general model. So, like around June, we had our government officials from the Ministry of Health, HPS, and also Department of Curative Services, PORAG, and Community Development, where the learning exchange visit, of course, with other development partners and implementing partners, including UNICEF and Irish Aid. And also Zanzibar was invited, but I think they were too busy by that time. We had a learning exchange visit in Uganda to learn this kind of entrepreneurship model. And the model actually, I would say, is working well in Uganda. And actually, we can say there are some challenges, not perfect, but the takeaway from the visit is that we can contextualize what we've learned from Uganda and try to pilot in our country. Yes, also for the entrepreneurship model that Monica is talking about, again, we had an opportunity to go and see how it works in Gaeta. It works well, and it is government support, the regional government support. And we also found that there are some areas to improve. So we wanted our colleagues from the government to learn how other countries are doing and how we can improve the model that is already existing in country. Yesterday, I had a little chat with Richard to share his experience on this. There are some doubts, as you are saying, the director, but we are still looking the best ways to move forward on what can be a motivational way for the CHWs to work hard. So from the donor perspective, we see this as something that we can support the government move forward, because out of that, we the government colleagues, I will say, together with the donors and implementing partners, came out with the way forward out of that visit. And one of them is to add the entrepreneurship sessions into the current training curriculum. And the second one is to pilot different models to see how this works. So we are looking forward to see this being tested, and to, like what the director said, to see if we can see these worries coming out, because what has been suggested, what has been said by the director is something also which was pointed out in a number of studies and cases. So as we are moving with this, let's see, and director, you will be part of this, and we'll involve you accordingly to see how this can work. Thanks so much.
Pascal, thank you so much for providing your guidance. I really like your response, Dr. Fatuma. I think the people in this room, you're leaders. Some of you are with government, others are with the civil society, others with donors. In the grand scheme of things, starting a national program like this requires that you're very careful how you approach the thing. Reason being, you have stakeholders like the parliament, you have stakeholders like the government and the minister. Once they see any problem, they hold everything. Community health is political in nature. I know that this model has been piloted in Uganda. I think I remember I was there when it was started, but remember it found other similar models. I don't know if you have other similar organizations in Tanzania. My view is, and I really echo your statement, Dr. Fatuma, take time, look at these innovations, because behind the community health work program, there are principles, there are core values. There are core values that determine you're promoting access to the most vulnerable people that are far fetched, that are located at the end of our communities, that are poor, so that you don't have this mother grappling with a kid with diarrhea, and here is a CHW saying the solution is this package. It comes at this amount of Tanzania shillings. Yes, it's possible. We need to test and pilot some of these innovations in particular regions, and that's what was done in Uganda. You have to try and test these innovations before you scale them up and integrate them in your guidelines. Innovations are good. I think CHWs, entrepreneurial skills are also good, but just know that even in your own government, you will never find a private sector facility in a public building. You never find a person running a pharmacy in a public hospital, which is private. So meaning their values, because the health you're offering the people is a right and a responsibility of this government. It's a right. This CHW is going to fulfill the mandate of government. I think your ministries of health have been established through certain statutes and acts of parliament to offer people services, not at any cost. I think Tanzania subscribes to that value, isn't it? We offer services. So innovations can be there, but we have a constitutional duty that woman down there in Morogoro gets a service. I've ever been in a setting where a community health worker was visiting a mother. The community health worker jumped feces in a courtyard to go and begin teaching a mother how to breastfeed, how to do it. Then I said, but I think you should also think about durable solutions in the home. There must be durable, and I think that's also the core of sustainability. There, you just can't come to someone's home. They have a garden, they have food, and you only tell them about these food supplements. You're dealing with malnutrition. I want us to step back. All of us have villages. Imagine your grandmother is looking after children of your late relative, and those children are malnourished. And here's a CHW walking into the home of your grandmother, telling her that these malnourished children, I have some tablets here. Vis-a-vis saying, grow some vegetable, wash hands, sleep under mosquito net. Which one is more sustainable? Or breastfeed if it's a mother. So, but the two work together because sometimes you need these products because they are valuable. That's why they are near policies. So I believe that both the mainland and Zanzibar take time, reflect about these models, and test them first. When you test them, you get the results, go to the policy makers. The good thing you have this steering committee, take them to the steering committee, they evaluate them, they make decisions, then you revise the guidelines. But once you've not yet started scaling up a national program, don't begin tampering with by including these things that you've not tested along the way. Thanks.
More hands. We have exhausted our 10 minutes for discussion. Can we move on? Okay. So thank you, Zanzibar, for the wonderful presentation. I believe you have taken note of the comments. It's just to help you think for the future. Yeah, even if it cannot be incorporated now. So you are discharged. Thank you very much. Let's give them a round of applause. So we are going to treat your presentation as one component. We will not include it into the mainland. So let's get it. You can share it with us. Share with the secretariat so they can adjust. So do the edit. Let's have it as soon as possible. Leadership and coordination, where are you? You have 10 minutes. This is also an important aspect of the program.
My name is Dr. May Alexander from PIRAD. I'd like to take you through what we have prepared in our group, the coordination subcommittee. In the assignment which we were given the day before yesterday, we had 6 priority areas that we managed to work on 4 priority areas. The 2 priority areas we found but in our group. So I'll show you here, and maybe you can tell us otherwise. So to start with, audit number 1 was to formalize and strengthen governance accountability and the coordination mechanism for community health at all levels, including the establishment of a national community health task force. Under this project, we have 7 activities. One is those reports the TOR and membership to improve functionality. During preparation for the CHTF meeting, I think it was last month, we came up with a suggestion that we think we have to review the membership of the subcommittees, also of the CHTF, but by doing so also we have to review also the TOR. So we think this is a very important activity, and by reviewing this TOR and membership, this subcommittee will become very functional, because we found some members who are not actively participating in this meeting. So this activity will take us through within 6 months, and it has no budget. Another activity is the development of annual CHTF calendar, plan, and budgets. Again, this will be done within 6 months, and also it has no budget. And the third activity is the regular convening of CHTF, including technical subcommittees. Here, we tried to put some budget. We put about 35,000 USD. And yes, knowing that this is a continuous activity, but again, within 6 months and within a year, you can take part of it to be in a CHAP. Yeah. Another is develop concept requirement for CHTF, which includes all information with links to dashboards, subcommittee proceedings, and up to date. Remember yesterday, Mr. Matiko from UNICEF tried to elaborate about this one. Because for us, we thought this is very important. We'd like to have an information hub where everything, all proceedings from the CHTF will be kept there. So we consulted ICT personnel, Mr. Matiko, and through that discussion, we came up with this amount of about 10,000 USD. We thought we think this will be enough for us, for the ICT people to construct this. This information hub, and similarly, we have to establish the CHTF web information hub. This will cost us about 15,000 USD, and again we have to operationalize this information hub by disseminating and orientation together with training. So this we believe also can be done within 1 year, and it will cost us about 10,000 USD. And the last activity of this is the strengthen administrative function for CHTF Secretariat through a full-time administrative staff. We know that we have a secretariat for CHTF, but again, we found it is very difficult for them to be active most of the time, because they have those in their offices. So we think that we have someone dedicated for this task, and this will be a full-time staff. And so we have managed to budget. We say it will cost us about 25,000 USD. The second priority was policy and integrate and regulate the CHW workforce and determine the best modality for a sustainable and robust training and the financing approach. But when we looked at it, we found that this is not true. The coordination subcommittee, and we thought it may be part of financing human resource subcommittee. So we didn't have any activity here. Third under the priority was revision of the national operational guidelines for community health. Here we had 2 activities. One is to finalize revision and the process for endorsement. We know that we have reviewed the national operational guideline for community health, and I think now is subject for signature for endorsement. But again, we understand that there are some documents which are coming in, and it's being signed. I don't know, they took to decide maybe to give us more time so that we can accommodate other comments and the ideas which are coming through. So maybe if not means we have a budget for it. That's why we have put here the budget to be determined depending on the decision from the high level. So if it will be yes, if it will be signed, then the announcement will be ready. So we found that this can be implemented within 6 months. Another activity is dissemination of the operational guidelines. This needs development of plan and budget, and if possible, leverage the existing platforms. We know we have this very common platform. We add more and do and from 2016 the country. And also from 1 to 4. This is we'll be convening in this meeting. So we think it's a good platform for us to disseminate this operational guideline. Or other platform can be used also. And we found that this activity is very possible because it can be, we're expecting this meeting within a year. But again, we couldn't come up with a budget because we need to consult other people also, so that we come with an actual budget here. So the budget is just not here to be determined. And priority is the criteria number 4, to manage the functionality of local governance committee to enhance community-based service delivery and documentary engagement. And this also we have the 2 activities. One is to review role of and the council coordination of community health services and the mechanism of linking local implementers with national level. We believe this we can accomplish this within 6 months. And also we have set a budget of $20,000. Another activity is to ensure SHW quarterly coordination meetings at regional and district level are conducted to improve functionality of regional and council level coordination with community health services. This also we believe we can do this, we can accomplish this within 1 year, a period of 12 months, and we have set a budget of $264,000 USD. And actually this activity for us, it is very important because what is going on at the national level, there's no communication with people at the sub-national level, I mean regional and districts. So we thought that this is a very important activity for the coordination subcommittee for us to keep them updated of what is going on at the national level. So we need to have these regional and district level coordination meetings so that we can keep them updated of what is going on at the national level. And another is criteria number 5, which is convene regular group meetings to improve alignment, coordination, and track progress in community health. But again, this we thought it is not ours. We thought maybe it is this is a repetition to the SHTF activities. So that's why we couldn't put any activity here. And the last It is reinforce accountability mechanism, foster contribution of community health to the attainment of the national and the global health goals. Under this, we have one activity, which is to identify and redefine accountability mechanism at every level of the health system. That is from the village level to the national level, and the linkages between these within available routine structures. We know that we have the existing governance structures down there, but maybe with this program, we need to find some of the accountability mechanisms to make these some structures make them to become active. Because current, and this will expensive this during the selection process. Going down there, we thought that we were going to use the so-called village social service committees, but when we were there, we found that these committees in some places are not existing, and other places they were there but dormant. So we end up using the so-called village committee instead of village social service committee. So this activity, we want to go back and see which will be the best way for us to going forward. So this is what we prepared in the team, the subcommittee of coordination, and Mr. Chair, going to present. Thank you.
So that's very comprehensive. Any comment? There's a saying that leadership is cause, everything is what? Effect. So without leadership, all that we have said here, nothing will happen. So this is an important component of the subcommittee. And I believe your priorities should be able to make sure that all the others are falling in place. Any comments from the floor? I think it's well understood, straightforward. Everybody is aligned. Also, yeah, so let's give them a round of applause. You are lucky. Nobody is asking a question. Yeah, so thank you very much. I think we have come to the end of the presentations. We've all done a good job. Now, what we need to do is to go back. The plan is to have the groups go back, all the comments that have come, polish the inputs, and then make sure you work with M&E team for it to be consolidated. So we indulge all the leaders, the subcommittee leaders, to please get in touch with M&E. Just clean your your documents and then get it to them. Once we do that, we have drafted the accountability statement. We would like to go through together. We want to be on the same page. Everybody knows what we are all committed to do from here. I believe we all have a role to play. That's why we are here. So we want everybody to know what we have put together. We read it if it resonates with all of us. If you have any additional thing that the drafting team have left out, then we can bring it. Especially Zanzibar, yesterday I'm sure we didn't get to you quickly, but you can take a quick look at what we have done, if it's okay, if you want us to add something else. And this document is really strategic. We want it to be catchy. Anybody reading it will be interested to come and support at the government level and partner level. So I will call Richard to take us through project is it? Oh, what's the time? It's 9:53. Let's do it before we go to tea. No, let's do it before we go to tea. It's 9:53. By 10:30, then we can go for tea, whilst the subgroups are finishing their work. So we've done some internal high high level politicking. So the agreement is that we'll go for a break. We'll go for the tea break. And at the same time, the subgroups, you will be cleaning up your work. So we are going to take 30 minutes to do this. It's just about 10 a.m. So by 10:30, we'll reconvene at the plenary to look at the accountability statement. So let's use these 30 minutes, take our tea break, consolidate, clean up all the documents, and then we can come back at 10:30. Are we okay? All right, thank you.
Are we all able to see? All right. Good morning, good afternoon. Is it a good afternoon already? It's a good morning. Habari za asubuhi. Asante. Um, let me start by, first of all, clarifying why it is important to come up with a statement. We technical people tend to think that the documents we work on are enough, but sometimes you have to make the technical documents sellable to certain decision makers. Once we agree the priorities, we also need to bring in our decision makers so that they own it. So that's why the accountability statement is part and part of the plan you're doing. It simply says, we have committed to do the things, we have to do them. I raise my voice. Can you hear me now? Okay. So that's why this accountability statement becomes very key. We've done this in the other 3 countries, we've done this activity, and it has been fully accepted and welcomed by Ministry of Health and other stakeholders. So the accountability statement has to really bring out the issues that are in those plans. But it's sort of like a call to action, asking us to make sure we take this work serious. So let me also appreciate the people who have put together this statement. It has been a collaborative effort. So many of you, Dr. Ona, of course, Dr. Fatuma, and the colleagues from Zanzibar, of course, CDC, our partners, UNICEF, USAID, and all other colleagues from the ministry that have reviewed this. This is your document, and I think credit goes to you. So this document has to be, we have to add the logo of Africa CDC. It's a document owned by 2 institutions. We shall work on that later, but in the most important thing for you to understand the content. So the first part of this document is some sort of preamble. These are the Dodoma recommendations to accelerate community health work in this country. It begins by highlighting that sort of the vision for Tanzania. We are at the moment trying to transform the community health program, and we, the people in this room, through the leadership of the permanent secretary, stakeholders, and implementing partners, we've come together in Dar es Salaam here. The reason we keep Dodoma because we want the capital of the country to be, the main thing. The United Republic of Tanzania, of course, mainland and Zanzibar, from this day, to forge a vision and a plan to accelerate the implementation of this integrated and coordinated community health workers program in Tanzania. Tanzania cannot continue with this fragmented and vertical disease-specific community volunteers. I think this is the core of the statement that came from Dr. Antuli and a few others. To address malaria, HIV, childhood illness and nutrition, and NCDs, we need to provide a robust primary health care services that respond to the health, social welfare, and nutrition services. We need universal health coverage that can only be achieved through an integrated health system that fully institutionalizes CHWs and ensures CHWs are trained, supplied, paid, supervised, and supported. So that's one aspiration we highlight here. We also bring the global evidence of the value for money, because we keep talking about, resource mobilization, but we pull in data. For every dollar invested in community health work, use $10 in other health savings. The impact may even be greater in Tanzania, given the important and effective health interventions digital can deliver, and does not account for the socioeconomic benefits. Does account, this accounts, sorry for that, it accounts the socioeconomic benefits and gender equity that result from a paid community health workforce that's predominantly female. This is the evidence. These are studies that have presented this. I enlarge. Oh. Is that better? Okay. The time is now to invest in our new community health workers. Tanzania's or the ICCHW program to provide a framework for aligning efforts, coordinating activities, mobilizing resources, and achieving impactful outcomes in the realm of community health delivery services. The program reinforces our mutual commitment to fund, scale, and strengthen community health work program for the realization of UHC and global health security goals in Tanzania. This program is a top priority in the government's transformation plan and will contribute to the ministry's vision of a health society with improved maternal and newborn child health, nutrition, sanitation, and reduction in NCDs, thus contributing to effective individual and national development. This vision is from the Ministry of Health website. Now, sorry? Newborn, okay. Thank you, capture. You capture that, I'll be able to. Anything you observe, feel free to, yes. I suggest that I first finish and then I get the comments. Are you suggesting that we handle it at a go? Is this okay? Someone is actually editing directly. Yeah, someone is, whatever you're observing is changing that. Okay, I'll pause from there and then take on the comments. Salim.
I just have like a suggestion on paragraph 1.
Yes.
Whether it will be relevant, you will see and consider it. So under paragraph 1, you have clearly listed the stakeholders and implementing partners. So I wonder if development partners are part of the stakeholders or they are different, because I don't see on that para a statement which propose the engagement of development partners, unless it's part of the stakeholder. That's my first.
Yeah.
The second one is on, I think, paragraph 2, where you mention,
So the comment on paragraph 1 is to be categorical and say development partners.
Development partners. Yeah, that's why I ask, do we
Yeah, they include stakeholders.
stakeholders?
Yeah.
Okay.
Because down there, they come out.
But also in this paragraph 2, I think it's critical that we explicitly include the NCD.
NCDs.
Because it's one of the major causes of morbidity and mortality. So unless we,
Okay.
yeah, and we know that these community health care workers play an important role in promoting these health behaviors.
Okay.
And I think on the paragraph 3.
Yes.
And no, I think it's 4. It's paragraph 4.
Yep.
Where you mention healthcare systems. I think it's important to make it clear that it's primary healthcare to achieve universal healthcare coverage. Where is it?
Okay. If we're to go down.
Yes, go down. No, should be up. Should be up.
So where we have healthcare system, we should be categorical and make it primary healthcare.
Yeah, primary healthcare, because that is the entry point of most people, and that's where the community health program is falling.
Okay.
Thank you.
Okay. I'm seeing another hand. My friend, we need to move the microphone. Bear in mind that some questions could be answered in the latter part of the presentation.
Thank you, Richard, for a good draft and a good presentation. On the last, this last paragraph, about the vision of the Ministry of Health.
Yes.
I see communicable disease is missing. I don't know if it is intentionally or since you said you picked it from the website. I find like communicable disease, which is part of the vision, is missing there. I see non-communicable
So in the
disease.
vision of government, there's communicable disease, right? Because what I'm reading here, the minister's vision of a health society with improved maternal and newborn child health, nutrition, sanitation, and reduction in NCDs.
I think communicable disease is part of that.
Okay.
Yeah.
So can we add communicable disease? When you read, educate me. Let's go to the vision. Dr. Ona, we're in the middle of the vision. Anything we're leaving out here? We don't want to miscommunicate. If communicable is there, we should then add it. Non-communicable disease and non-communicable. Okay.
Yes. In addition to that, I think I'm also missing emerging and re-emerging conditions. So,
are we reading the vision?
Yes.
Or we are advocating? You know, everybody in this room is an advocate. Okay, if there's communicable, we should add communicable. Myra, add communicable and non-communicable disease. That's contributing effective to individual and national development. Okay. We can also go back and recheck the vision to ensure that we are totally aligned. All right, let's quickly rush to the next part so that, but if you still have a question, we'll come back to that. Now, I'm seeing a hand. Yes. All on board.
Okay, thank you very much. I think before we move on the paragraph of Tanzania cannot continue, can you go?
Come again? I go back?
And you go back?
Okay, which paragraph?
I think it was, yes, from there, the Tanzania.
Okay.
There is a statement that you address that to address malaria, HIV, childhood illness and nutrition, and communicable disease, there is a need. Instead of writing, we need.
Okay.
Yes.
There is a need to provide. Okay, thank you so much. Myra, there is a need to provide. Yes, I agree. I agree. Okay. All right. And Myra, read the next part. Read from we need universal healthcare coverage. Read the next part and refine the language there. The idea is that once we finish here, we're going to make the final changes. So your comments are valuable, extremely valuable. So let's go to the affirmations now. Sometimes a statement requires to acknowledge what a policymaker is doing. You don't start by stating problems without recognizing the investment, the leadership and the current response is happening in the country. So we need to build this statement through an affirmation that there is so much progress we've seen in Tanzania, a lot of investment and commitment. So this is the second part. So the integrated coordinated program contributes to the Africa Union and Africa CDC's 2 million committed workers initiative, which Dr. Barnabas talked about, and the new Africa Public Health Order. These all argue that all AU member states support and facilitate the implementation of this program. So what do we mean here? That we are part of the larger, bigger goal, a continental agenda and also a global agenda. These documents you see mentioned by Dr. James and Barnabas, Tanzania was a signatory. So, secondly, we also recognize that through MH leadership and pure large, all partners should be able to commit to the implementation of this program. Mobilize financial resources, including domestic resources. Yes, please. Yes.
The document should, we have to recognize that we have two ministries of health, so the document should reflect that.
Okay.
But I'm not an Englishman, so I'm not sure if it should read with the leadership of the ministries of health,
yes.
and that should reflect throughout the document.
Yes.
Otherwise, it looks like only one ministry.
Yes.
Of course, we are looking at Tanzania, but unfortunately, Tanzania has two ministries of health.
Agreed.
So,
yeah. So let's Myra, that's a good one. We have to make sure that the two ministries are reflected across the board. I believe the pure large is one. Is that correct? The rest is okay. 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 So we want to believe that all partners commit to the implementation of this program. We want to see increased financial mobilization, including domestic resources, partner alignment to this program, country-led coordination, which already I think you have one, to ensure one plan, one budget, and one M&E for this program. Yes. Yes.
Including domestic resources, it means is by the way. But for sustainability, it is better to start with domestic resources. Yeah, we need to put up a mechanism to mobilize domestic resources. Because if we increase domestic resources, the likelihood of sustaining the program is very high. So can we rename that, rephrase?
Okay. Sometimes what we do when you say resource mobilization, put in bracket, either foreign and domestic. Because here's the thing. Sometimes also reality has to check in. We cannot plan for resources we don't have, but we are going to seek for them. If I'm to tell you right now, the training that is supposed to start on the 23rd of September is funded by not the government of Tanzania. That's correct. So now we cannot let that go. We have to ask for more while sustaining the flow, the inflow of these investments. So I think I hear you that we need to be cognizant of the fact that we need to emphasize that the gap is that the government is not putting in money. But given the program needs of this country right now, we do not have enough resources from the government to keep the momentum or to run the activities we want to do. So I still think next year, this country will be applying for another cycle for Global Fund. Is that not correct? Are those domestic? But we need to ensure that the ministries keep looking for more while asking our own governments to increase the allocation. Yes.
I think outside our normal thinking.
Yeah.
How is then African CDC assisting member states to advocate for more domestic resources rather than depending on external?
Okay. Dr. James, do you want to come in there? How is Africa CDC?
I think one of the things all of us agree that for self-reliance, we must self-finance. That there's no argument about that. And the self-financing might come in different ways. And I think one of the things we've been doing over the last 2 years has been supporting countries develop and increase domestic fiscal space. Domestic fiscal space, some countries have innovative approaches. That's what we call innovative approaches, especially for community health. If you look at what Rwanda is doing, it's innovative. They have decided that they incentivize community health workers by creating cooperatives, and they put their salaries or a portion of their salaries in those cooperatives, and the community health workers can go and take loans at 0%, and it develops fast. Botswana has a different model. Ghana has a different model. So there are different options of increasing domestic fiscal space. Some people are putting taxes on cigarettes or alcohol to be able to fund public utility services. So I think the ultimate goal is for us to be fully self-reliant either through ministries or the PPP, the public partnerships. We have Airtel, we have Tigo, we have all those people. They can. So I think the ultimate goal for Africa, if we are to secure our own health security, is to have self-funding. And as much as possible, we are trying to work ourselves in weaning out the dependency on ODA. Because at some point, everybody would also have problems and they will focus on their own internal dynamics. So I think that is the ultimate goal. And that's what we've been doing. And I think AFF, IFRC, our colleagues in the room here have also been doing that. And I think maybe we need to domesticate. We've been doing it at the regional level. Maybe we need to have country dialogues on how to increase domestic fiscal space.
But I hear you. I hear your argument. That's why we emphasize when you hold some of these engagements, we need parliament in the room. We need parliament. You know? Yes, there's a hand here. Dr. Salim?
Thank you. So I would like to contribute on the bullet that starts with a healthy population.
Yes.
I do agree with all what you have put, but I think under the provision of quality health service, I think we need to reiterate the need for equitable. It should be quality, but it should be equitable, but it should be also affordable. So, because when we put all those elements, that's where we will operationalize our health insurance and other mechanisms for health financing carefully without leaving anybody behind. So maybe we need to find a way to incorporate those qualities, but also to achieve that. Of course, it's through collaboration with other stakeholders, but also since here we are talking about community health, part of that to achieve that is through investing more on the primary health care. So I don't know how, but we need to say that.
Okay.
So that to pitch this primary health care, to pitch this community approach very high so that it reads the same everywhere.
Okay.
Yeah, thank you.
I think, Myra, you can say provision of quality and equitable healthcare. I think equitable incorporates the other thing you said, but I agree with the idea that by increasing investment in primary healthcare, I think that's more direct and yes. Good. So the next one is that we do recognize that we have a shortage in healthcare workers, especially at the primary care level. Is that percentage, Myra? I think it's the health population, the first plate. When you go, a health population is crucial. Go back. So, do you agree with the percentage that the shortage you have stands at 52? The current coverage is at 52, which goes up to 70% in some regions. Those that are data rich. Yes. Because we found this in I think partly what the presentation. Yes.
So I'll not talk about the figure, but always I would like to reiterate what Dr. Fatma has mentioned, that we have to, be reflective of the, two ministries, and whatever we put there, let's see what Zanzibar has and what mainland has, and then put the figure in between those two. That is my first comment. The second comment.
So before you go to the second comment, can you tell us what Zanzibar has? What's the strategy?
We have to check. We have to check the human resource. Where does it stand so far?
Okay.
And then on the second part, which say increase in disease is related to, this is a correct statement, but I don't know if it is very well linked with the first comment.
I think it's yes.
It is correct, but it needs a strong, it needs to be rephrased to
there's
make
an
a
increase.
connection.
Yeah, there's an increase in behavior-related diseases like NCDs. I think we can paraphrase that. Myra,
but also maybe because the shortage is not static, it's dynamic, and we know that there's a growing population. I mean, there's a huge population growth rate. There is also those emerging and re-emerging diseases which demands more skills, more people to address them. So we can also we have a new data from the, what is it called? Census, which shows how the Tanzania population is growing. So no matter how many healthcare workers you have today, in the long run, with a growing population, with the emerging disease, then this will not remain the same.
Okay. So I think you're qualifying the next one. We're saying now, with an increase in this burden, including NCDs and a growing population, this might even increase further, this shortage. So let's capture that detail, Myra. So the next one now is that we are also recognizing that in the United Republic of Tanzania, despite the importance of CHWs in advancing PHC, there's still a challenge in coordination, management, and training of CHWs. These bottlenecks may stand in the way of realizing UHC goals by 2030. 2023, the Ministry of Health, in collaboration with the Pure Large and partners, launched the program. And we are now acknowledging the policy shifts this country has been making. And the United Republic of Tanzania, I think, I think it was one statement. Okay, put it together. Sorry. The 5-year program seeks to scale up CHW programming to increase population level coverage of life-saving interventions, contribute to universal health coverage, and end preventable maternal and child death by 2030. We're still focusing on the vision of this program. We are also talking about the number of CHWs to be trained and deployed in the certain catchment area as indicated there. We go further to talk about what the program strives to achieve in delivering the standard healthcare package, strengthen linkages between communities and primary care facilities. We then go to talk about the money, how much money we need required, because we said these documents are also going to be used for resource mobilization. Not only do we talk about the money we need for 5 years, we talk about the money we need for 1 year, which sort of speaks to our accelerated plan. Then, after stating that problem, yes. There?
I think it's not there.
Okay.
Yeah, and even the CHW requirement.
Okay, that's a very good one. Can we get the budget for Zanzibar included here, including the 1-year budget? Yeah, give us that. The intention of this makes that we align the two. So give us the total budget and the projected number of CHWs, plus also the budget required for the first year. All right? Thank you. Yes.
So
Salim.
on top there, where you listed some of the challenges in implementing primary health care, you listed a number of things, including training, including managing.
Yes.
But I think the whole issue of formalizing, because formalization comes with all those elements, but those elements, not necessarily, you know. So I think the word formalization, because
Should be including.
formalization requires the political will. While other people can pay for the training and that, but formalizing this cadre is very, very important. And probably we may, like advocate for the member states to, to gradually formalize and institutionalize this cadre. It's missing there.
So we're saying that there seems to be lack of effort to fully institutionalize CHWs.
It's not, there are efforts, but of course, as we all agree, it's not an easy political decision given all the cost. And this is, we are saying already that there's a shortage of healthcare workers. So the government has to strike a balance between, investing on this lower health cadres vis-a-vis mid-level and higher level. So it's not like the government not doing anything, but it's still a challenge.
So the efforts are suboptimal or are not sufficient enough to formalize, because just like you say, this is a process.
So for
Formalization.
example, there, without maybe condemning the government, or where we say there are still challenges in coordination, management, and training. So I think we should start by saying there's challenges in formalizing, because within formalization, then these elements will always be in the process of formalization. So that formalization, you can coordinate, you can manage, but formalization and make sure that CHW are included within gradually included in the
workforce.
The workforce is a bit.
I know what you're trying to say. You're right. You're trying to be sensitive, not to annoy the politicians. You don't cut the branch on which you're seated, right? So I think let us start to put the word formalization. We will manage it with Dr. Antuli and and Salim. So we do also recognize that the 5-year program seeks to achieve. So let's add the numbers, the budget for Zanzibar, and the numbers to be deployed, and also put the 1-year budget so that we can have the mainland and Zanzibar. So we acknowledge what the 5-year program is trying to achieve, talk about the numbers, talk about the budget, get us the numbers. Then we focus on what we feel is working before we go to commitments. Since the development of the roadmap in 2023, the government, with support from partners, has made some strides in building this foundation. Through focusing on systems thinking, I saw that from both Dr. Salim and Dr. Antuli. There's service integration. Both your presentations have talked about an integrated package. There's been thinking about gender, job creation, and some evidence-based decision making. When you had your delegations visit other countries, your benchmarking, but also we've seen some political championship. Tanzania took part in the recent World Health Assembly. Tanzania has been involved in a lot of global engagements. They are planning to bid in UNGA, and Africa CDC is actually going to, and the AFF are going to showcase your work you're doing. This work, by the way, this very month is going to appear. We have people in this room that are organizing UNGA. So we are, and that requires political leadership, which you're doing. So there's some progress on that note. We also see that there are some mechanisms to ensure efficiencies with greater focus on governance, accountability, and coordination. We already have a national health task force. Those are progresses. We also see that the program has worked to build credibility among partners at national and international level. Both bilateral and multilateral partners are involved in supporting Tanzania. That to me is a good stride. And to sustain and consolidate these gains achieved so far through this program, and to strengthen government stakeholders and implementation partners, we collect the outline and make the following recommendations. So, not only are we interested in this maintaining the momentum, there are particular things this meeting is proposing. One, Tanzania mainland. There's an understanding that we want to move away from this room and hold advocacy engagement with government. When we say government at the highest level, we don't only mean departmental heads. We mean the minister, the vice president, and the president. And the good thing, we have the office of the president represented here. We have Zanzibar in the room. So we need that high-level advocacy to implement this community health acceleration plan, which all the different work streams plus Zanzibar have put together. We also, mainland has planned to develop investment case as a tool to guide resource mobilization efforts and advocacy, include mapping of these resources to increase our envelope for this program. I know that these efforts are already there. We just need to ensure that they are materialized. We need this investment case. Dr. Antuli talked about it here in his presentation. It needs an investment case. We also need to roll out the training of CHWs in the 3 clusters. The number 2,800 has been very visible in all presentations for Tanzania. So training needs to be effected. And I think September, the first group has to be there. So this has to be a priority. We also need to revise the integrated service package and training curriculum because these tools move alongside the training. So again, that is a top priority for mainland. We've got to initiate the process to develop a comprehensive community strategy to ensure that it aligns with the national roadmap and priorities. There's an understanding that the country needs a strategy. When we say initiate the process, it means we're starting, from concept level, look for a partner willing to fund it, or government itself bring the money. We've got to start. This takes long. It could take another 3 years. But what we're saying this year, let us kickstart the process. And lastly, develop and implement community-based self-service program, which will be responsible to oversee the system and address the program elements indicated there. That is also a priority. Dr. Ona thinks this is a top priority for the mainland. Rose.
I think bullet point 3, 4, and 5 are part of the community-based health service program. And I also don't think we are developing it. I think we are implementing. So I would take that whole paragraph and move it up as bullet point number 3. Yeah, so and then it would say implement community, which will like that.
Okay. So saying that it should replace, we move it up. Okay. It should become bullet 3. Okay. Well, I'll align on the language. Align on the language. You're the stars. Yes, Dr. Hassan.
Yeah, a small addition.
Yes.
On the investment case, I don't think that we just want to develop it. I think it is developed for a purpose. So
And operationalize.
exactly.
Okay.
Otherwise, it will be there sitting
Okay.
on a shelf.
Thank you. What did you drink this morning? Yeah. Papaya. I need that. I need that. Asanteni. So I think yes. Bullet. Actually, Sasa, let's give these numbers so that people don't suffer with bullet 3. Watch out to work in any.
The bullet
Yes.
3, fast track.
Fast track, yes.
A space between fast track, fast and track.
Okay. We have real land people in this room. Thank you. I appreciate your parents for paying school fees.
There is another person.
Tunashukuru. Yes.
Sorry, I'm just keeping you back and forward,
Yes.
back and forth.
Yes.
I want to everyone to be clear when we are saying investment case, because this tool should be used as an advocacy tool.
Yeah.
I think it is important to make sure that it is having life saved, life averted, incorporated within that investment case. Okay?
Yes.
Is it clear for everyone, or who is developing that one? Because it is important. Having resources without, for a politician or anybody, without telling him that this amount will avert these lives, it is not so. It is missing something.
So I think, Rose, you need to engage a stakeholder to refine the language. But I think she's saying a word that we should add to advocate for resources. Yes, Dr. Salim. Myra, add instead of to guide.
It's very
advocate.
important point, but I think, I don't know whether it's a rule or what, but usually all investment case has something called return of investment. And this return of investment, it could be in the monetary terms, or it could be the morbidity or mortality, which is averted. So I think most health economists, experts will have that in their mind. And yeah, but I also want to raise like, we have a bullet number 5, which say initiate the process of developing strategy. But bullet number 6, it said develop and implement the program. So I wonder which one should start, because I believe strategy should guide the program. And if that is the case, then this strategy should not just be initiated. It has to be developed to guide the program. Unless, in terms of hierarchy, let's see which one is the umbrella of the others and see.
In the real world, you're very right. But in the current state of affairs, we are building this boat as we sail it. You come from the islands, you must relate to that very well. I think what we realize that, and not only Tanzania, many countries have gone through this. Community health programs have evolved from certain intervention and opportunities. Then as you walk backwards, as we learn from other countries, you learn that, hey, we need a strategy. We just did something around the CADA, CHW. We need a strategy. So, but that does not stop the training work going on. So once Dr. Ono thinks we need to continue implementing this program, is saying along the way, it must sit in a strategy. Yeah, because politicians will ask you, do you have a policy? Do you have a strategy? Okay, that is mainland. Let's go to Zanzibar. Revise the 5 years comprehensive strategy to align with the existing national roadmap and priorities for the provincial government of Zanzibar. That's one. They want to focus on this. Continue with the high-level advocacy meeting with the government and the highest level funding agency, new and old, to mobilize resources, just like the mainland. And I think Dr. Salim came here. He was doing his work. I guarantee you, he's coming to New York. He's going to do his work. So the hand that looks for money can never stop. Thirdly, continue the rollout of training program of the training program for the 3,000. We acknowledge that these are already being trained. We feel they must continue and they finish. Hold high-level advocacy engagements to bring in to mobilize resources to procure the 3,000 bags. Now, that is separate from the ongoing resource mobilization, because this one is very targeted to the bags, because the trainees need the bags. But as you look for money for bags, you can't stop to think that actually some donors or partners need to increase investment in the overall program. So that's how the two differ. Of course, we have these have to be deployed within the shortest period, and continued development of the investment case as a tool to guide resource mapping and resource mobilization. So those 6 are the priorities of Zanzibar. Now, we've indicated the immediate priorities of the 2 ministries. We want to conclude. This document has given us the preamble of where things are in Tanzania. They have given us the major problems we see in our country. It has also given us an understanding of what we're doing right and why is it that this is right. What do we need to do to move forward, and how do we conclude? The evidence is clear. Partnerships and shared responsibility approach are critical elements needed to reach the last mile, ensuring impacts of the community services. Community health services delivery attained at all levels in the Republic of Tanzania. The role of these stakeholders and implementing partners work hand in hand with the leadership of the ministries. We need to clarify that. And PLRG is a key approach to success. And the task force is a vehicle to improve upon system strengthening, integrated health service delivery. And we know that the ministries are in the driving seat. There is momentum to realize the full potential of this program at scale. And we need everybody on board. So we end up by drawing a picture for you that actually this program is the vehicle. This kind of vehicle has a driver and a co-driver. I don't know which one is the main and which one is co, but there are 2 drivers. Our role as partners, stakeholders, is to get into this vehicle so that by 2030, we realize UHC and ensure that this community health program has been operationalized. We're seeing the reforms needed. Asante. So I'll hand over to the moderator of the session. I think your quick feedback has been very, very, very valuable. We are going to make sure that we incorporate them so that you own this document. I'm seeing some 2 hands. Finally, the politician is awake now. Dr. Alexander, yes, I think there's a hand down there from Dr. Alexander. Oh, I've not shown you who are going to sign. That's what you're saying. This man. So we have about 5 signatories. Number 1, the Minister of Health and the Minister of Health for Zanzibar. Dr. Fatima, here was aligned, right? The 2 ministers are signatories. Then African CDC is a signatory. The chair of the Development Partners Group is a signatory. And we also wanted to recognize that there are 2 ministries. Maybe if we also want to have Dr. Salim, we can have, we also need technical people, not just a political leader. So the Director of Preventive Services, Dr. Antuli, and Pure Large, we also want to the Director. Dr. Alexander can tell us whether this is the right title. We should also add, I was looking for the title of Dr. Salim, whether it's the director or program director or of programs? Okay, good. So we're having these two and then ending with the pure large. So politically, we want to have that correct. So let's make that adjustment. Then we'll have all these people signed. Are we missing anybody? Very, very important.
Okay, thank you very much. I think you can take as an advice and still make some consultation. I think to could state the ministers of health, it's okay. The Minister of Health and Revolution Government of Zanzibar, it was okay. But I think after that, it could be the PURAG, the minister. If you go down, you have right director of community health, but I think it could state the minister in PURAG. Then I think before writing the director of preventive service, the program is so technical. I could suggest you rather maybe use the chief medical officer.
Okay.
It ended that. I think you may take it as an advice, but you can make some consultation.
Does the chief medical officer also oversee Zanzibar? No, that is advocacy. They are speaking the same language. So, okay. So do we agree that we remove these two directors and put CMO and Director General? So we're adding the Minister of Pure Large and then adding the Chief Medical Officer and the Director General. Good. Easy. Yeah. Yeah. Good. Okay, thank you so much. In the interest of time, I want to go and make these changes and avail the documents for the next steps. Asanteni sana.
Asante sana. Let's appreciate for the great job we have done to develop a very strong commitment as an advocate tool commitment statement. So far, so good. As we are waiting for the guest of honor to close our technical discussion platform, let's go back to our groups for around 30 minutes in order to ensure that all those comments which have been given during the presentation are addressed, and the consolidation team, the M&E and ICT team, to ensure that you consolidate that document, and thereafter we shall come back for the closing ceremony. Asanteni sana, naomba twende kwenye group zetu. Dr. Mkenda, do you have any? Kenda.